Well, good afternoon, and thank you for spending the day with us. And this is the last panel program. I want to warn all the panel and the audience that Alan Enthoven's in the audience, and he's the great knowledge. Hello, Alan. Anybody else? Any of our grade beards? No.
Notables. Yeah.
Notables, thank you. Well, I want to thank the panel for being here to talk about California's new health care exchanges, which I think for most people in California, they have no idea what they are or what's coming. And I would guess that a lot of those present are much more familiar with them. But I think it's a very interesting and topical subject. And we're very fortunate to have a great panel. And Marian Mulkey, on my far left, is the Director of Health Reform and Public Programs for the California Healthcare Foundation. And Sarah Varney, on my left, is a reporter with NPR and the Kaiser Family Foundation. And Tom MaCurdy is probably known to many of you as a professor in the economics department here at Stanford. So thanks to the panel for being here. I'm John Freidenrich, and I have no idea why they asked me to chair this panel other than I have been a long-time director of the Stanford Hospital and Clinics, and at one time chaired the board at Packard Children's, and have an interest in medicine here at Stanford, but no degree. We'll have three presentations, and then we'll have about a half hour for questions at the end. And I think we would like to start with Marian Mulkey, and then we'll go left, and right. Thank you.
All right. Well, thank you so much, and it is a pleasure to be here. So I am Marian Mulkey with the California Healthcare Foundation. We're an independent philanthropy based in Oakland, and I think I'm probably here as a next best to somebody from the exchange, since they're all so busy that they have more trouble getting away from their day jobs than I do. I wanted to just start. My job mostly, I think, is to set the stage a little bit for the context and the implementation steps that California has undertaken to date. But I wanted to start by asking you all, since I expect I'm in kind of a mixed group, how many of you would consider yourselves very familiar with the Affordable Care Act? Those were the two I knew. How about exchanges? I'm guessing, yeah, maybe a couple more.
The PX, you mean at the Air Force, the PX?
Yeah, and not kidney exchange either, but rather the construct that's in the law. So I'm going to lay some groundwork here, and Peter and Alan will know this, but I think it's important context probably for the rest of us. We heard this morning, those of you who were here, from Mark McClellan and Zeke Emanuel, some of the big picture national and international comparisons about cost in the U.S. But to drill down one level from that aggregate spending that they were talking about, health insurance premiums are very expensive too. And those of you who bargain them or might happen to pay them entirely out of your own pocket know this. But an awful lot of us don't know how much health insurance costs. So just as a reference point, in California right now, a employer-sponsored health insurance policy costs about $6,000 for a single person and about $16,000 for a family. And of course that cost is largely not visible because most employers contribute most of that cost. And if you do go and buy your own policy on the individual market, it's a little bit less than that because the benefits aren't quite as good. But that's your reference point. So compare that to median income of in the vicinity of $50,000, $55,000 a year, and you see why it is that people struggle to afford coverage. Employers struggle to afford coverage too, especially smaller ones or ones with lots of low-wage employees. And so we've seen a trend over time in California and in the rest of the country toward declining employer-sponsored coverage. We have many people who, for whatever reason, are not attached to an employer who offers coverage, and so their option, if they aren't quite poor and otherwise eligible for public coverage programs, is to go and buy their coverage on the individual market. And that is a deeply flawed market in its current incarnation. You can be turned down from participating in that market based on your health history, your health condition, and you can be charged very high rates based on your previous risk as well. And the reason for that is not because insurers are bad, although people can argue whether they are good, bad, or indifferent, but rather because it's a voluntary market, a market in which people choose to participate. And of course, people who think they will have higher health care needs have stronger incentives to want to participate in the market than those of average or excellent health. In terms of the characteristics of the uninsured in California, they're disproportionately likely to be self-employed or work at small businesses. They're disproportionately likely, of course, and unsurprisingly, to be in low-income families, and they're disproportionately likely to be Latino, even compared to our population. Just another point of reference, we have a public health insurance program for low-income people called Medi-Cal in California. It's our version of the federal Medicaid program. And while it covers nearly 8 million people right now, it does not cover all low-income people by any means. You have to qualify for other reasons as well. So that's kind of the backdrop in California. And those factors and those contextual issues were very important for some of the conversations that California has had in its own state house over the years about whether or not to do something to reform healthcare finance. And there are certainly factors in the federal conversation around the Affordable Care Act as well. So what's in the Affordable Care Act? Several big provisions around coverage expansion, as well as a complicated financing structure and many investments intended to address some of the ways that care is delivered and paid for as well. But in terms of the coverage expansion provisions of the Affordable Care Act, the law does several things. First, it envisioned a broad expansion of the Medicaid program. The notion in the law originally was to bring everybody up to a certain income band, 138% of the federal poverty level, or a little over $15,000 a year, into eligibility for coverage. The court decision last year actually ended up making that more or less optional at the state level and will introduce much more variation, as we heard this morning. The Affordable Care Act also puts in place some significant reforms to the individual market, requiring that all health insurance carriers sell to all comers. The term of art is guaranteed issue, and also imposing a mandate on consumers to obtain coverage, either by purchasing it themselves, enrolling in an employer-sponsored plan if they have that option available, or enrolling in a public program if they qualify for that based on income. Now, the penalties are modest if they don't comply with that mandate, and that is a subject of some concern for some. But that's the notion, is that everybody has to sell, everybody has to buy. In addition, to make that market or to help that market work better, there are these new entities called exchanges. In California, which was one of the first states to establish a state-based exchange, that entity is now called Covered California. And the role that the exchange plays is to organize the market, to present health insurance options in a way that can be compared and understood by consumers, to give consumers an easy way to figure out what public programs or financial assistance they may qualify for, and importantly, to be the sole place where consumers can access fairly significant federal subsidies to offset the cost of health insurance. So, what has California done so far? It has taken a number of steps in legislation to enact provisions of the Affordable Care Act and or to bring state law into compliance with the Affordable Care Act. So I mentioned we were the first state to establish an exchange following the enactment of the law in 2010. That was done in the Schwarzenegger administration. And the way that California set up its exchange is as a selective purchaser. That is, the vision is that the California exchange will look at the market, establish criteria, solicit bids from plans, and present only the ones that, as the language of the law states, provide the optimal coverage of value, affordability, choice, and several other things. I forget exactly. Anyway, the idea is the exchange sees itself as an active purchaser that will help to make a more rational market. California also has enacted a law around defining essential health benefits, which is a term included in the law, and that will define basically the minimum level of coverage that can be sold and meet the criteria of compliance with the Affordable Care Act. And right now, there's a special legislative session going on in Sacramento. You may ask what makes it special, and that is that the usual rules and the timeline for enacting any legislation that is passed is accelerated relative to a normal session. And during this current legislative session, the expectation is that California will move to enact that Medicaid expansion, but there's a debate going on right now about the implications of that expansion for state and county finance. The other remaining piece of business that California needs to engage in through a legislative process is to enact individual market rules that comply with the Affordable Care Act, and that too has taken a little bit longer than some folks thought it might. So that's kind of on the legislative side. On the side of the administration, there are a bunch of tasks as well that are underway. I will focus particularly on the exchange because that's the topic before us today, but it is not a small thing to undertake this Medicaid expansion on the public program side either, and if people have questions, we can talk about that more as well. Some of the big tasks that are on the plate of the exchange in California, as they are for the federal government, as it administers exchanges for some of the states that aren't establishing their own exchanges, and for the other states as well, include developing a eligibility determination and enrollment information technology system, figuring out how you can elegantly and easily and accommodate people, sort them into the different programs that they're eligible for, and connect with existing other programs or with private plans as appropriate. There are big plans underway for doing extensive outreach and marketing of the new opportunities available under the Affordable Care Act. This room is not unusual in not understanding everything there is to understand about the Affordable Care Act. It's a really big, complicated law, had a very extended timeline, and there's a lot of work to be done to let people know what's available there. And of course, this process of contracting with health plans, selecting the ones to be sold, negotiating with them, administering the business relationship is a very significant one for the exchange. So that's kind of my high-level overview. There are many open issues about how this is going to work and how well it's going to work, but once we get to questions and answers, I expect we'll get to that. I left you two handouts which illustrate a couple of things, and let me just tell you what they are because we probably won't get back to them again. This, with the teeny tiny print on the very big paper, is a timeline of the California state implementation activities around the Affordable Care Act. Probably nobody in this room wants to study this in any detail, but what it's intended to illustrate is two things. There's a lot to be done, and it happens over a really long time period. And these are both resources from California Healthcare Foundation. You can get them on our website if you want. And then this, kind of on the other end of the spectrum, was our best effort to kind of boil down into 2 pages in reasonably accessible language what the law does for people in the state of California. And it describes, you know, depending on where you are now, what will happen to you under the law. So those are both just for your interest. If you're interested in, you can feel free to leave them behind if you're not. So again, I really appreciate being here today and look forward to the discussion and the other conversations.
Well, thank you, Marian. Sarah?
Thank you. So my job is basically to cover health reform in the states, and there are 50 of them. So I've been on the road a lot. So what's been great, though, is historically I had just covered California, but now I've been able to go to Arizona. I'm about to go to Mississippi and Texas. And so really sort of getting on the ground and seeing where this stuff is working and not working, and the kinds of conversations that are happening in places like Texas, obviously, are incredibly different than the kinds of conversations that are happening here in California. But it's hard for me to sort of separate out the exchange for the exact reason that Marian said. So I think it might be helpful just to sort of, I'm going to cast a bit of a wider net, if that's okay, and just talk about the sort of scaffolding that's being built right now. And while it's a really exciting time to be a health reporter in the United States, I think there were many people, and people who have been doing this work much longer than me, who said, you know, if I have to do one more story about some poor guy who didn't have health insurance and, you know, ended up in the emergency room and ended up bankrupt. I mean, we were all just doing these stories, obviously trying to illustrate the impact that this was having on people's lives. And I think the final one for me that really got me was, this was right before the law was passed, and I was doing this story about teenagers who were uninsured. Their parents earned too much to qualify for Medicaid, too much to qualify even for healthy families, and you now had this sort of growing rank of sort of middle-class teenagers who didn't have insurance, and it was embarrassing for them because they would go to sign up for the soccer team, and you had to show that you had insurance. So it was starting to have kind of a social impact in, I think, the lives of people that you really would anticipate would be isolated from this. So I think many of us are just relieved that, in a sense, then how we feel about the reform, that at least in our minds, like, the narrative has changed, and so now we're chasing it off in a different direction. It's also a difficult time because right now, like I said, they're sort of building the scaffolding. So there's a lot of sort of if it rains stories, as we like to say. You know, what if they don't do the outreach right and nobody shows up? What if we get too many sick people in the pools and then the premiums go up too high? So what I am out there looking for are sort of things that I can kind of knock on and see and actually sort of observe changes in the marketplace or at the kinds of things health plans are doing. Just a couple things that I've sort of seen over the last couple months or so. There was a story that I did recently that was about these in kind of thinking about how are providers even thinking about changing. We've heard about affordable care organizations, people kind of coming together to sort of knit together the specialists and the primary care physicians and the hospitals to sort of take greater responsibility and financial responsibility for the health of their patients. But one of the things that I found were these bodega clinicas in Los Angeles. I don't know if you guys have spent much time down in LA, like in Huntington Park, where it's almost exclusively Latino immigrants. And these are like these storefront cash-only clinics that are very common in Central and South America. And you would think that a lot of the people who would go there are undocumented and uninsured. They're actually not. Many people who go there are documented. Even some of them have insurance. They just can't use it anywhere. They might actually have Medicaid, and they can't get into a clinic on a weekend, for instance. But there's this one big clinica chain called Clínica Mi Pueblo, and they recently just sold several of their clinics actually to a big managed care outfit called Molina. Molina does a lot of work in the managed care space. Because the clinicas sort of see the writing on the wall. They say, well, actually, all of these cash-only customers, many of them are going to start getting insurance. And we're not really set up to process all the payments and deal with, insurance plans and those sorts of things. So there's actually I like sort of looking on the outsides of the market and sort of seeing the changes that people are kind of already making. And I think sometimes the people who run bodega clinicas and those kind of operations are they're sort of on the leading edge, I think. So that was one story that I did recently that where you could actually go and sort of see things changing already. The other thing that's really happening also down in LA, our public health departments are really keen on getting their house in order. So if you can imagine right now in Los Angeles, for instance, their clinics and their hospitals are basically the place of last resort. And what we saw, and Marian can tell me the exact year, but when women became eligible for Medicaid with their pregnancy, they left the public hospitals and they went to private hospitals and they brought that payment source with them. And so a lot of people in the public health departments, Mitch Katz, who's down running LA, their big health program down there, he used to be up here in San Francisco, they're really keen on this. And so they're, when I was down there, this was a while ago, but they had like assigned 250,000 people to medical homes over the course of just a couple months. And the overhaul that has to happen in a place like Los Angeles is just extraordinary to prepare themselves to get ready for this. The other thing that I find kind of interesting, and especially since here we're in Silicon Valley, is, and this has been going on for some time because obviously venture capitalists are paid to be smart and make money with other people's money. I'm a reporter. I'm not. But one of the things that's interesting is that venture capitalists are really changing what they invest in, right? So it used to be that somebody would come up with this $4 million robot, and every hospital would want to get one, and every hospital did, and that's in part why we have such high medical costs. But now what they're hearing are that hospital administrators really only want to spend money on things, on services and products that save them money. So, for instance, one venture capitalist told me that, if you come in with a device that's 10% better and twice as expensive, it's hard to get anyone to care. So the share of venture dollars that are flowing to the seed and the early stage investments in biotechnology and medical devices has really plummeted. I mean, that's really been since 2007 with the Great Recession. But venture capitalists are really eyeing businesses that do things like help hospitals keep patients from returning back to the hospital, because now they are going to be dinged by Medicare for what we call unnecessary readmission. So if you come back to the hospital within, I think it's 30 days, for sort of an unnecessary reason, something that the hospital could have prevented, Medicare is going to ding you. And this is actually having a big, we're actually starting to see real changes in hospitals now, in how they're organizing themselves when they dispatch patients. So I think a lot of people see a lot of opportunities within these sort of complex healthcare ecosystems. One of the areas is something as mundane as billing. I mean, you go to some of these hospitals, and these particular groups or divisions are oftentimes off-site, but they have like armies of people who just do billing. I think they employ more people in the billing department sometimes than actual doctors, it seems. So one of the things that investors are really looking at is sort of investing in companies that basically can automate billing, something as kind of mundane as that. So, and then the last thing I'll mention is sort of the managed care, which we are very comfortable with here in California. I think 70% of Californians, something like that. Pretty high percentage of Californians are in managed care. You can think of Kaiser Permanente. Well, one of the areas that had not been involved, that managed care had not been involved with, were people who were so-called dual eligibles. So these are people who are eligible for Medicare and Medicaid. And there's this big part of the Affordable Care Act. There's this big pilot program, it's even more than a pilot because it's millions of people, is to move some subset of the 9 million dual eligibles into what we would consider managed care. So having one entity manage both their Medicare benefit and their Medicaid benefit. And we were just in this last session, somebody asked this question about, well, where are we spending a lot of our healthcare dollars? And a big portion of it is with the dual eligibles. These people are the sickest and the most vulnerable people in the country. And I was just in Arizona, and it was really interesting because they there actually, with their finger-wagging governor and their hatred of the Obamacare, they do a really fantastic job actually with their duals program. And it was interesting because here in California, there's a lot of concern that managed care companies perhaps can't take good care of these vulnerable people, that it's just kind of not in their DNA. And it was interesting to go to Arizona and be kind of pleasantly surprised that managed care companies could do that. So I know that sort of gets beyond just the exchanges, but all of those things actually flow out of the Affordable Care Act, and it's sort of difficult to isolate one piece of it without talking about where the exchange is sort of pushing up against other areas of the healthcare industry. So.
Thank you. Tom?
Okay. What I'd like to do is give you kind of an overview of the fiscal aspects of ACA. ACA is the Affordable Care Act, and that's what it's usually called. And let me just note, I'll give you both fiscal impacts for the nation at large and then California. As has been discussed, the increased coverage, health insurance coverage, is really it's meant to do this through three main vehicles. One is the healthcare exchanges. The second one is greater employer coverage. There are penalties to incentivize employers to cover more of their workers. There's this expansion of Medicaid. And I should give you some context on the expansion of Medicaid. Right now, Medicaid covers up to about 100% of the federal poverty of families at the federal poverty level. Children under 6 are eligible up to 133%. What ACA does is basically also make older children and adults also eligible for that. So that's primarily the expansion of the program. Also, one thing else I should note is for those states that are not expanding their Medicaid program, they all are going to be eligible for getting insurance in the exchanges. So there'll be federal subsidies for those individuals as well. And
Actually, just a little slice of it.
yeah.
Not the 100, not up to 100.
I think, well, we could talk about that, but I think that CBO, when it did its pricing, that's essentially what it did. And there's a legal issue in terms of where they're actually going to go, but it pretty well looks like that's what they're going to do. Certainly in the pricing, that's what they did. And so I'll be talking about the numbers that basically have that sort of built in. Now, the major challenge, of course, is that premiums are expected to go up a pretty significant amount. And to just give you an idea, we're talking about 30% or so in real terms relative to what we've had in kind of the recent years. So the challenge here is how we're going to pay for all this. One thing else I should note is that while they're expected to go about 30% or so for the exchange, for the employers, it's not anticipated that premiums will go up nearly as much, partly because there's already a pool there and there's already a system, et cetera. One of the other challenges in the exchange is, according to ACA, the ratio of the highest premium to the lowest premium, it has to be 3 to 1. Under current law, it's more like 5 to 1. And what that means is the premiums for the lowest, the youngest, most healthy workers are expected to go up pretty dramatically. And there are projections that will literally double relative to what they've seen in the past. On the other hand, the premiums for the elderly are actually expected to fall. So this is kind of a transfer again from the younger generation to the older generation. Now, what are the incentives to obtain higher insurance? There's penalties and there's subsidies. Let me first give you an idea of the penalties, and I want to give you some idea of what the magnitudes are. There's penalties on employers. For those offering insurance currently, if they drop their insurance, there's a $2,000 penalty per worker if they don't do it. Now, that's for larger firms over 50. If you're a smaller firm, there's not a penalty essentially imposed on that, at least under current law. But there's a penalty on that side. Now, there's also penalties on individuals if they don't obtain insurance. And let me give you an idea of what those are. And they're basically related to your income. So if you're an individual with income of $15,000, in 2014, the penalty is only $95. It grows to $695 in 2016. So that gives you an order of magnitude of what the size of the penalty. If you're an individual with $100,000 income, the penalty is $900, about $904 in 2014. And in 2016, it's about $2,200. And if you're a family with income of $25,000, it's about $285 in 2014, and that grows to a little over $2,000 in 2016. And these penalties grow. So it gives you an idea of the order of magnitude. So basically the penalties are not that high relative to what the projected insurance costs are going to be. But in 2014, it's a $95 penalty if you're a low-income individual on that sort of thing. Now, what about the subsidies? Well, for the employers, there are a small part of subsidies. If you're a very small employer of less than 25 workers with an annual payroll of less than $50,000, so these are really small employers, there's a 50% tax credit if you didn't have insurance and you now provide it. And that's really what's called the small employer tax credit. And then uninsured individuals below 400% of the poverty level are eligible to receive subsidies in exchange. And let me give you an idea how generous the subsidies are, because they are large. If you have a 4-member family, and I'll project the premium to be at about $7,500, and that's a conservative low premium. If you have an income of for a family that has $30,000 income, the subsidy is about 90%. So the subsidy is about $6,500. So it's about $1,000 that the family's putting in for their insurance. If that family has an income of $50,000, it's about $3,500. If I jump to an older family where as their insurance costs go up, their subsidies go up. So let me go to the older family, say family in their late 40s, early 50s with teenage children. And suppose you set the premium there at about $15,000. If they have a $30,000 income, their subsidy is $14,000, close to $14,000. So it's about $1,000. If for a family that has $50,000, the subsidy is about 75%, so it's about $11,000. So I assume your first reaction is, okay, that's great, but where's the money going to come to pay for this? And that's really where the huge challenge is. So how will ACA be paid for? There are obviously three sources. One is from the private side, because you have employers and individuals, families paying higher premiums. There's the federal government and the state. And the federal government's bearing most of the costs here. So let me go through what the issues are there. So what are the federal costs of ACA currently projected by the Congressional Budget Office? And these are numbers that are literally out February 2013. And I can talk about disputing those numbers, but I'll just give you those. The cost over the next 10 years is $1.9 trillion. Now, in 2014, it's projected to be $50 billion because we grow this sort of thing, and I'll explain why there's so much of the cost loaded in the back, but it's $1.9 trillion. That's a lot. $50 billion in 2014. By 2016, it's $150 billion. Now, just to give you an order of magnitude, food stamps are about $70 billion. So it's a little less than 2014, and it goes past food stamps pretty rapidly after 2016 and grows dramatically after that. Now, what are the revenues to cover this? Well, the revenues come from four sources. There are the penalties I just mentioned, the payment of penalties by the firms and by the individuals. There's an increased income tax on higher income individuals. There's kind of a SIEPR payroll tax that's like the current Medicare tax that's been increased. There's a tax on certain manufacturers and providers. You probably heard about the device tax and all that sort of thing. So there's some money comes from that. And then there's an excise tax on higher premium insurance plans, but that doesn't start till 2018. So a lot of the taxes I'm talking about don't even occur until start in this 10-year window until 2018. And about how large is that revenue going to be? It's about 20 taxes in all kinds of forms. It's about $500 billion. So it's $500 billion. Let me just note the costs are about $1.9 trillion. It's over the next 10 years. It's projected about 35% of those tax would be paid by families below $250,000 of income. Now, in 2014, it's only the revenues for this are only about $6 billion, because once again the program is loaded backwards, so most of the money comes later in the 10-year window. So it's $6 billion, and they rise modestly. They don't rise very much until 2018, when in fact the surtax comes in on the higher insurance plan. So essentially, there isn't a lot of funding for this program for the next 5 years or so. That's the main message to take away from this. Now, what are the projected net effects of ACA on federal deficits? It's $1.4 trillion over the next 10 years. That's what's left uncovered. In 2014, it's $40 billion. Once again, that's a little more than half the food stamp program, just to give you an order of magnitude. It grows pretty rapidly after that. In 2016, it's $127 billion. Now, what about California? Let me bring it back to that. So what's going to happen? What are the effects going to be in California? California, not worrying about its tax side and its share of the debt, all the states in some sense gain here a lot. It's projected that more than 1 million Californians will receive subsidies in the exchange. These families, as a group, will be estimated to get about $4 billion in subsidies in 2014, to give you an order of magnitude. Somewhat less than another million Californians are forecast to become newly eligible for Medicaid. And the state agencies project about 800,000 greater enrollment of Californians in the current Medicaid program, because they expect the ACA to basically induce more enrollment on that side. What's the cost to California? Out of the general fund, it's about $700 million. That's about the order of magnitude that the state agencies, the Department of Health Care Services, projects. Now,
I think the state budget share, though, is 350. I think that might be Fed and state together.
No, that's the general fund part. There's a dispute between the UCLA and the UCLA CalSim model and the Department of Health Care Services, what the take-up rate is going to be for the other part. So there's a range.
The budget ask was 350.
Yeah, but it's politically. So there's a number, and then there's the politically mentioned one. But it's less than $1 billion. Let me just note that. So, I mean, it's no matter what, it's not like the federal kind of dollars here. So it's not $1 billion. It's nothing to us, but that's kind of the variation you get in the Medicaid budget just year to year. So it's kind of that order of magnitude. And essentially what California has to do is just pick up its half for the current program of any increase in enrollment. That's essentially what's involved. Now, I know I'm a little over, but let me just note, the current estimates are very likely to be low, and there's for a variety of reasons. So these are not high estimates that I'm going through. Let me just note a couple things. The take-up in the exchanges are predicted to be are lower than one would predict, at least I would suggest are going to happen. Just to give you an idea, it's projected for families that are eligible for a 75% subsidy, only 60% will take it up. And if you expand that, you can move the deficit, the federal deficit, up to $50 billion in 2014 without any challenge. The other big point that isn't really mentioned is all these models essentially assume that if the employer covers the employee, they'll cover the family. Those are all done in the cost projections. The penalty only applies to the employee, not to the family. So what you want to think about is if you have a low-income family and the employee gets their insurance and they can see that their families are eligible for subsidies, large subsidies over in the healthcare exchange, you might want to ask why the employer would be picking up that money. And once you start making those adjustments, there's going to be a lot of cases, at least in the not too distant future, where the employee is covered by the employer and their families are covered in the exchange. And as I just went through to give you an idea of what the size of those dollars are, and it's pretty large. Also, then you already know about this issue of the penalties for the young are not very high. In fact, our insurance rates are going to be pretty high. So there's a real challenge here of the healthier people not going into the exchange, not covering, not being there and only coming in when in fact they have healthcare events, which is going to be another challenge. There's a lot of challenges we basically face in terms of these dollars. So these dollar figures I've kind of given you are I would say on the conservative side. So it's going to be a challenge because we don't have this is kind of an unfunded kind of activity for the next 5 years or so. Okay.
Well, that's quite. This is on. I want to thank you for that. We're going to take some questions. Zeke Emanuel, who's a well-known expert, I guess I would say, in healthcare in the U.S., spoke earlier in the day to the main conference, and afterwards we were discussing this program, the exchanges, and one of the things he said was that he is concerned that people understand that there are going to be a lot of hiccups along the way with the exchanges, issues, problems, whatever, especially in the first 1, 2, 3, 4 years of it. And people should not believe that this is going to solve every problem and all problems and immediately. So I wonder if anybody on the panel has a comment about that.
So few things solve every problem immediately. And no, I don't think the exchange will. And I think that, the history, I took two things away from that panel this morning, that everybody on both sides of the spectrum and with lots of knowledge expects that this will be a slow, phased-in implementation, that day one things won't go perfectly and that there will be bumps in the road. And I think that the experience with most big public programs and probably most big changes of all kinds are consistent with that. But I also took Mark McClellan's point that, over the long arc of time suggests that there will likely be learning from that and probably acceptance if indeed people value the coverage that is provided through these channels. And time will tell what the quality of the products are and how managed the costs are, such that whether they can be sustained or not.
I would say that, I feel like there's sort of a couple of different ways you can look at what's going to be successful. The one is just, I think there are many people who are just sitting there thinking, when you flip that switch, does the thing turn on? Literally, the computer, the website. So I think there's a lot of people obviously working very hard in Washington right now and in Sacramento and all over the country trying to just literally build the back end of this thing. But I think, so that's sort of the first thing. Does it just literally turn on and work? Or are there major technical challenges in the first couple months? There will be technical challenges, but literally are systems going to be able to talk to each other? I think the second thing is, if you're concerned about enrollment and you want to, if the goal is to get as many people enrolled as possible, you want to know if people are going to show up. It was just in a exchange board meeting in LA, I don't know, 2 months ago or so, and they're talking about who are going to be these assisters and assisters and navigators. I always want to say and brothers, who are literally going out and like knocking on doors and going to 7-Elevens and going to churches and asking people, do you want to sign up for health insurance? And we need to do that in Spanish and in Chinese and in Hmong and in every other for people who are deaf. I mean, every single person who's eligible is probably going to need some help, and how you assemble that army is really critical. So I guess that would be the second thing. And then the third thing is really, so then people get the insurance, they get the plans, do they use it? Does it actually help them control their chronic diseases? And in fact, the exchange in California is being very smart about this, where they're actually, I don't know if this has actually been put in the regulations, but at least it was floated, and I think it was pretty much adopted, this idea that the health plans have to ensure that their new enrollees actually get in to see the doctor. So like within 90 days of getting the new plan, that you get a call that you get enrolled, that you get a call from your doctor. If you have chronic conditions, that you're in some sort of disease management. So it's trying to prevent against this idea of, okay, we're going to enroll all these young people or people who have not had insurance before, and then we're just going to collect their premiums. Thank you, federal government, for that nice subsidy, and we don't have to deliver any care. So there are people really thinking about, okay, the mark of success is not only getting it turned on and getting people enrolled, but actually getting people into care. And then I think the fourth thing is this question of cost, and that feels so far in the future. I'm not sure how to gauge that, at least from where I sit right now.
Tom, do you have any comments about this?
No. I think that's probably better. No, you guys did a great job, so it's nothing really checking out on this.
Here you go.
Tom, one of the big uncertainties, I think, I just want to ask you to comment on this, is the CBO, in making its projections of cost to the federal budget, assumed that employers would stay in the game and most employer-based insurance would continue, and so that wouldn't be a cost to the federal budget. But other people analyzing the whole thing, looking at it, say that is a very big attraction for an employer to reorganize somehow, so we have a company that doesn't insure at all for our low-paid people, and those people go to the government, and so there maybe many million people will get their insurance from the exchange that were not assumed to do so in the CBO estimates. Do you think that's...
Yeah, I totally agree with you. I didn't mention that as one of the reasons for you would project higher costs, because a lot of people kind of hear that, but I totally agree. The forecast that they have here is that most employers, even with a 30%, with these large increases in premiums, will keep health insurance for their employees. And as you probably have already heard, there's a lot of discussion where, in fact, that may not occur. But this family issue is even a bigger one that I don't think has really been looked at very carefully. And that's a challenge, because look at the employers, obviously, the kind of model that a lot of people are assuming that's going to take place here is it's not that the firms are going to cut their compensation to the employees. They're just going to give it more in the form of earnings, which CBO believes they're going to do. And then you go off to the exchange. But the subsidies are large for if you're talking about kind of a fast food worker with a small, young family and the like, subsidies the subsidies are large. And the employer is going to be doing, in some sense, their work as a favor by saying, look, I'll cover you. Here's the $2,000, and your family goes off to we'll go get an extra $10,000 or $5, $6, $7, $8, $9,000, $10 in the exchange. And both the employee's better off, the employer's better off, and they're getting coverage. And those sorts of factors are not accounted for in these costs. So this, even this 1.4 trillion, it's good reason to believe that's an under forecast. And especially once I want to note is that cost up front, where we're kind of assuming a slow phase in, is we don't really have coverage for it. So
I have a question maybe for members of the panel, or maybe somebody in the audience who knows something about it, but who's going to take care of these patients? Where are they going to go? Who's going to provide the care? Are the hospitals still going to have emergency room coverage and so forth? How is that addressed?
the notion is that this builds on the existing health plans and provider relationships that exist today. And for the people who are covered, presumably the health plans will negotiate contracts with plans and providers as they do today. And to the extent that there is a huge infusion of people, and again, there's both the fear that we'll get so many people that we won't be able to afford them, and the fear that we won't get enough because the penalties are like, so, remember that this is an uncertain thing. But if there are lots of new people, indeed, there will be demands on access systems, and in some parts of California and in many states, the providers won't be sufficient to provide care in the way that we with employer-sponsored coverage are used to getting today. Now, what are the solutions to that? They are many, many. Sometimes it's about looking for alternative ways to deliver care. Sometimes scope of practice is the word that Sarah just said, that is looking for less skilled providers to provide some types of less technical services. But there's certainly a matching issue that will be a challenge. Will emergency rooms still have to treat and stabilize people? Yes, they will. This doesn't overturn the federal law that requires that. Will there still be undocumented people who don't qualify for any new benefits under this program? Yes, there will. And so to the extent that we as a country have decided we needed to have a publicly funded safety net as a provider of last resort, that need doesn't go away.
I would also add that the community clinics will play a big role in this, and there's been a lot of money poured in. I'm sure many of you are shaking your heads or nodding in agreement that, the community clinics have received a lot of money over the years to really build out. And I think it's important to keep in mind who some of these customers are going to be going to the exchange. Many of these people, they're obviously uninsured now, but they're oftentimes a pretty low income. They just too high to qualify for Medicaid. And obviously the exchange is really thinking about this because they're thinking about these sort of bridge programs where, part of the year you qualify for Medicaid because you're not out in the fields picking, and then during the time of the year when you're earning an income, you could go into some sort of bridge program like a Medicaid managed care program. And many of those people are used to going to community clinics. They like the community clinics. I think the community clinics deliver, in some cases, really fantastic care. They've adopted electronic health records. In some cases, they're really on the cutting edge. They're not just sort of Soviet-style buildings with no plumbing. They're quite extraordinary in some cases. So I think that, as much as people can be inventive in thinking about how to get the community clinics to play a role. You don't need to go to Stanford as much as it's wonderful. You can go to your community health clinic, and that'll suffice. Not to slam Stanford.
Well, actually, I should note, before you start talking about the exchanges, it doesn't work so great right now for Medicaid or Medi-Cal in California. Most of the individuals who are in emergency rooms are on Medicaid. Yeah. So. Yeah. Right. So you should probably suggest that, and by the way, it's from California's Medi-Cal perspective, that's not necessarily a bad thing because it can be a very effective way to triage patients. But this notion that, I just want to note, most of the patients by far that are in emergency rooms are on Medicaid, and that's partly because the reimbursement rates are pretty low, and there's a whole separate kind of provider community for Medi-Cal in California as opposed to the regular providers. Just to give you a sense, the fee schedules for physicians have been held down forever. So much that if you, for some evaluation appointments, you would go in for a doctor, the payment's $15. So, as you might surprise, it's a great deal. If you get it, you don't get it.
Oh, sorry.
We'll get you next. I'm sorry, next.
Thank you. Who, anybody in the panel can answer this. Who, if anyone, in this new world has an incentive to undercut pricing from a competitor's price? Everywhere else, people are trying to undercut somebody else's price so they can get more customers. Who in this new world has that incentive? So, for example, are these urgent care facilities going to be actively seeking to divert people from emergency rooms to them? And are they going to do so in a way that ultimately will save some money?
Super interesting question. On the exchange side, the subsidies actually are linked to the second lowest cost offering in a certain level. So health plans have an incentive because the presumption is people will want to use the subsidies to their greatest effect, they have an incentive to be relatively cost effective. So there is some competition built into the way the subsidies are structured and offered through the exchange that gives plans an incentive to be cost conscious in a somewhat different way, depending on how contributions are structured today in the employer market than they have at a lot of places today. So that's one place. I don't know. What else would others?
Well, actually, I'm more optimistic. I mean, if you take the Medicare prescription drug program, which has competitive bids, in sharp contrast to the managed care programs in Medicare, which isn't based on a competitive bid system, those programs compete pretty effectively. I mean, they do. I mean, and partly because they want to. There are two things they want to get. Is they want to get the individuals to enroll in their program, and individuals pay a lower premium for a program that's cheaper, and Medicare is pretty rigorous about providing various quality measures for the programs in terms of measures of performance, issues on patient safety, issues on truth in advertising, and all that sort of thing. So when you go to the Part D prescription drug sites, I mean, they keep prices low, so they get larger enrollment, and there's a star system that indicates how well the programs have performed in the past. So it's actually a system that works pretty decently, and that's one thing nice about ACA. I mean, I've talked about some of the cost sides, but it was set up in a way so it shares many of those features, in sharp contrast to managed care in Medicare, which has really it's not really a competitive system, and they have this benchmark that's kind of a made-up benchmark and all that sort of thing. So it's kind of not, it's problematic. But there's good reason to believe that the systems will be competitive. The challenge here is what do you call a benefit package, and you start stacking more things on the benefit package on that sort of thing, and it drives up the cost. And that also happens in Part D, the prescription drug program. But it works pretty well.
We heard this morning about wouldn't it be, can you imagine an Amazon-like approach in order to be able to really put price transparency and therefore price mechanisms into the health system for a variety of different services from device to delivery, et cetera. Is there any conversation as you think about what the back-end system is going to be for the exchanges that will provide, as you said, active purchasing so that the right information can be presented in the right way so that consumers can become more educated more quickly and more agile? Is there any conversation about who else is going to want to share that system and what benefit that might have for broader health care?
So here's the challenge in my mind, and this is a bunch of economic people, so you'll maybe get what I'm about to say. The problem is the unit of analysis. The problem is what it is that you're looking, and competing on. So this is structured at the health plan level. Below that, health plans are contracting with doctors and hospitals are contracting with device manufacturers, and there are so many inputs that get rolled up into that health plan level that even though I believe California's exchange and probably many others are interested in increasing transparency, the layers of opacity beneath that are deep and are not, I think, going to be undone through this particular mechanism. I think that there's a lot of interest in making progress toward that, but really, we don't know how much health plans are contracting with hospitals for, on a per day basis, on a per device or procedure basis today. It's between the two of them. It's negotiated behind closed doors. And, some states have made moves toward all payer claims databases where at least you could get that information in the aggregate, even if you didn't in the specific, which could at least start to allow people to understand where, for example, market concentration might be driving up prices as opposed to utilization or salaries or whatever else it might be. So, there I think will be modest movement toward that. I think there are other efforts underway that could help that in sort of, in a little bit piecemeal fashion, but there's a long way to go.
I mean, I think that one of the challenges, I kind of rephrase your question slightly different because that is definitely an important issue of how much you pay when you go in for services. But what's happened, and ACA has the same problem, is Just to give you a baseline here, if you take a look at the fee-for-service kinds of data for the Blues plans, the Blue Cross plans, about 40%, anywhere from 30 to 40% of their costs are in the top 1% of beneficiaries in that year. So you have these really high cost cases that just come in and really blow. If you had a profit margin, that's what blows it apart. All these plans have a max out of pocket so that patients don't see any of those costs once they're up there on a cost share basis. And you may have prices advertised at that point, but the question is, well, who's supposed to stop? Who's supposed to kind of, in some sense, limit the amount of care at that range? And that's one of the challenges we have that's pretty formidable. It certainly is the case that if you go in for an x-ray, you want to know how much it is. And the people who tend to know that are the ones who are on these medical savings accounts where they're paying the full amount and they kind of ask for it. And if you talk to individuals you can negotiate pretty effectively with doctors in terms of their price if you have a flexible time and you pay cash. That's well known in the business, and same with the communities. But it's the high cost individuals. All our money, like in Medicare, probably 2/3 of the expenses are in the top 90% or top 10% of the beneficiaries with cost, and they don't see any expense. So how we limit that, there's going to have to be some kind of limitation of services there. And if the patient were seeing the price, they'd have some involvement. But if they don't, there's going to be some other set of rules. And that's one of the features that ACA has, is this 15-panel member that's supposed to, in some sense, say, well, these services are allowed and those services aren't. And by the way, every plan's got to have this to some degree. So it's just an issue of how you institute and what roles people have. So that's one of the real challenges.
Yes, in the back of the room.
Thank you. In terms of the cost of trying to get, say, younger workers into these pools, or just younger people, if we're saying that the penalties are very small, if the premiums are going to go up at least 30%, what's the incentive for a younger person to even sign up? Because you have to get covered. And what does that build into some of these deficit estimates? Because I don't see how young people will come in because the price is so high compared to, in the exchanges with what's happening with the coverage.
Well, for the cost projections that I gave you, it's assumed they're going to be in.
Do you really think they're going to be in?
No. Well, and many people who did the cost estimates, when you look at the appendix, they're worried about that as well, because that's exactly the problem. And notice it's 30%, but for the young, the arguments are it's going to be 100% increases. It's pretty large because it's a 1-to-3 ratio.
So what does that do to those estimates if you just wait till you're sick or you wait till there's an accident?
That hasn't been, we don't know.
So I will say that the structure does contemplate an annual open enrollment period, so there isn't complete moral hazard. That is, you have every year you get one chance to sign up, and if you don't do it, then you bear the cost in the interval. Sorry, I had a second thought.
The other thought I think, which is, I think you were going to say, is that a lot of young people have fairly low incomes, so they will qualify pretty significantly for the subsidies. So even though the premiums will probably rise pretty significantly, if you're earning $25,000 a year, you'll qualify for a pretty significant.
But if you're describing the penalties as $100 a year,
right?
So that's for the first year. I will say, having done a lot of reporting over the years of these so-called, what do they call them? Young invincibles. I have not been able to find a young invincible. I mean, generally when you talk to young people, it's like, of course I'd love to have health insurance. I'm not an idiot. I just can't afford my rent and my car and my school payment. And so I don't know. I think, sure, there's going to be some people who say, forget it, I'll just pay the $95 penalty, and then as it goes up, I'll keep paying it. But I think, by and large, young people are fairly smart and get the impact. And if they can afford a policy for $1,000 a year with a subsidy, I don't know. My bet is they'll do it.
Well, we need.
We got to go to Vegas. We got to have like a book at Vegas.
Having more low-income young in the program isn't helping us here. We need the $100,000 young in the program.
Well, I would like to be one of those 100,000.
I got that part.
It's really hard to know how people will respond to all these incentives. But remember, health insurance is very expensive. We can argue about whether it's worth its full cost, but it's worth something, right? So it's really not $295 penalty or $95 penalty versus nothing. It's coverage at 100, whatever that subsidized fee is versus the penalty. And you're right, people will make rational decisions, but people's sense of risk aversion and what is rational for them may not be as clear-cut as just the dollars.
Gentleman over here.
Sometimes to wrap my head around this, I mean, if I compare another exchange like the auto exchange, the car insurance, you don't get penalized if you actually drive well, right? In this case, if you're healthy, you actually get penalized, you pay more. Are there other competitive things that are actually built in that actually, give you incentives if you're actually healthier? So just as an example, in Japan, you actually pay less if your waist size actually goes down. Right, so obesity, so they have related obesity to higher health costs. So they've actually done this very successfully. So you pay more. You can go eat all the Doritos you want, but then you end up paying more because your waistline has gone up. Right. So you have other sort of things that have actually improved the healthcare costs. And Japan only pays 6% of GDP, and they have healthier people than we do. Right. So do you know if there are other competitive sort of built-in pressure walls that actually improve the overall cost?
Actually, I don't. There aren't. I mean, now I think plants might be. They're smoking. That's the main one. So essentially, the rules are that, abstracting from if you're a smoker, there can be a differential. But other than that, with regard to premiums, there's a lot of flexibility. You can't do gender differences, but you can do differences by age. It's just in the end, the lowest premium to the highest premium to the lowest premium has to be. Can't be above 3, so it can't be 1 to 3 factor other than that. But I don't know that
there are a bunch of provisions.
There can be rules that allow you to you to do that.
Employer-based coverage to do a lot of things that employers have begun to experiment with already in terms of worksite wellness and incentives toward diet and exercise and all those kinds of things. And they're actually, and this is not something that I am deep on, but I think they actually put in the law pretty aggressive opportunities for employers to differentiate premiums by those levels. And the presumption is that if that is, if that is taken up and successful in the employer-based setting, it'll move quickly into the individual market and the exchange as well, I think.
Yeah, one thing that's interesting is the only thing that is prevented, that the employers are prevented from gathering in terms of information about their employees, is gun ownership.
Well, on that note, can we take one last question? Young lady here.
I didn't, but
correct me if I'm wrong, but I believe managed care is supposed to help bend down the utilization curve when you compare that to fee-for-service, correct? So if that's the case, but we also want to do more with preventative care, how do you actually balance the idea of providing X-rays, more effectively, not providing what's not needed and what's not essential, but on the other hand, engaging in preventative care, which does call for more tests, for just catching things earlier on. How do we actually, so I believe California is actually trying to reduce its utilization rates, for example. How does it actually do that while increasing the prevalence of preventative care?
Well, I should note that the notion, and Alan probably yell at me at this, but the notion that managed care saves money is not true in Medi-Cal, for sure. And that's partly the way that it could, but the way it's priced in Medi-Cal is the problem, because they have what are called carve-outs in Medi-Cal, and what that means, as soon as the patient gets too sick, they throw them off into the fee-for-service kind of category. So, managed care really has to be kind of just, and on the other hand, if you take Arizona, the thing that's nice about the Arizona Medicaid, that's another program I should have mentioned that's a really good program, because Arizona's Medicaid program is a competitive managed care-based system. And if you're high in the price, you don't get enrollment in those systems. And the quality is kind of checked year by year, and it's a system that works extremely well in that regard. But the notion behind that is, if you're the managed care program and you're going to be keeping this beneficiary for a while, you do have the right incentives to try to make sure that their costs aren't high downstream. If there's rolling enrollment all the time, you don't have that. But in those systems where there's this long-term relationship, and you would expect the healthcare exchanges to establish long-term relationships. If you're you can't raise the premiums enough on the individual. So if you don't keep them well, you're bearing the cost on this sort of thing. So it's next year, the following year, et cetera. So the incentives are built here in a way that we don't have so much in the current systems. I mean, obviously, if a health insurance plan plans on going in the exchange and out of the exchange, and that's an issue. But most of these are long-term players. They're going to be there. They want to keep their patients, and they realize if they're not doing the right things now, next year they're going to pay for it. So, and there's been some work done and evaluation done of Arizona's system, and that seems pretty consistent with that. So these markets can work to some degree. I mean, they're often not permitted to work.
Well, thank you all for being here, and the panel, thank you very much for your participation.